Right. Just want to remember, last night I was emailing somebody in Darwin who I do a bit of work with, who has a really hard time finding honours students. She works at the Menzies Health Centre in Darwin, does a lot of work on Haemophilus in Aboriginal kids. So if you think about doing honours, just bear in mind it's possible to do honours somewhere other than here. How we'd arrange it, I'm not sure yet. Probably would be you'd enrol here, do some of the stuff here, but you'd fly to Darwin and stay there, and do some stuff there in their laboratories at Darwin, at the Menzies Health Research Institute. So there's options available. So just think about that. Another thing too is they do a lot of work there on PhD, so if you wanted to take your honours to go further, they do a lot of work there in Aboriginal health. It'd be really awesome. Just have a think about it. Okay, so we've had a look already at fungal diseases that are superficial, and we've talked about cutaneous disease caused by dermatophytes, and now we're going to move on and look at the things that are subcutaneous. This means the infection goes deeper beyond the skin surface into the muscle, below the muscle, in the fat layers. These are much, much worse. Cutaneous disease, bit of tinea, no problem at all. I'd have it any day for a bit of fun. But one of these are nasty, and they're disfiguring, and they're really hard to treat. They're also really uncommon. They're much more common in developing countries, but they do occur in Australia, depending on your situation. They're more common in Australia in the tropics, say Northern Territory, far north Queensland, and less common in colder climates, but they're pretty important diseases. In terms of the kinds of bugs that are involved in these diseases, it ends up being the bugs that are dermatiaceous. These are the pigmented dark fungi, and mostly it's the ones in this group that are slow growers. So in this group there are some that are really fast, some that are really, really slow. The ones you see in these diseases tend to be the ones that are really slow growers. Not always, but usually very slow growers. And there are some that are hyaline hyphomycetes, not dermatophytes, in the others group. Things like Fusarium, Scedosporium, those kinds of things. Doesn't involve zygomycetes, does involve dermatophytes. In the end, there are some things about these infections that are common amongst all of them. There's some differences, but the overall, in general, the etiology, the causative organism can be a whole range of fungi, but the underlying common thing is they're almost always caused by things from the environment, and they involve some kind of traumatic implantation. These fungi just don't sort of float around, land on your skin and start burrowing in and invading you. You need to have some kind of trauma involved that implants the spores somewhere deep in the tissue. Something like walking around with bare feet, stand on a twig, walk into a tree, crash your bike into something. Something that involves penetration with something from the environment that contains fungal spores or fungal elements that are implanted deep inside you, then they grow. They tend to be slow growers, so the disease is chronic. It's not as though you have the injury today and next week you are sick. It's injury today, injury heals, and then there's a lump, and the lump grows and gets worse, and it might be 6 months, 12 months before you even have any signs, and sometimes it can be 10 or 15 years before it's really, really bad. And in developing countries where these things are more common, because healthcare access is so poor, you notice something's wrong and you go, oh, it's a bit of a nuisance, I'll leave that, and it gets worse and worse and worse, and in the end it's so bad it's incurable, but it's disfiguring. They don't kill you, they just make you really non-functional and they're unpleasant. Because they involve traumatic implantation, they're non-transmissible. Really, of all the fungal diseases, it's really only dermatophytes that are transmissible between people. You can't catch this from somebody else. Even though it might look unsightly and not very nice, they're not contagious. Sometimes what you see is a very non-specific foreign body reaction. That is, you've got something in your tissue that shouldn't be that's growing, It's not part of your body, and you mount an immune response. It's a foreign body reaction, and you wall off to an abscess or a big sort of granuloma, and then physically it's got mass to it and it grows over time. Sometimes, though, there's a very specific way in which your body responds that's quite different. So it may be a cross between being non-specific or being very, very discrete. And because in medicine we like to put these in categories, some of these diseases are given special names with certain criteria that means it's in that box now but not that box. In the end, for the person, it doesn't make a lot of difference whether it's in this box or that box. It just helps you for diagnosis and to keep a record of what's going on. So the 4 different kinds of diseases that we cover in this little topic are like this. One is called sporotrichosis. You have sporotrichosis when your disease is caused by the organism called Sporothrix schenkii. So this disease is defined not by the lesions or how sick you are or anything else. It's defined by the organism. If you have this bug, you have this disease. And as it works out, because this organism causes a certain kind of disease, you tend to present in a certain way, and the therapy is fairly similar. So it means that having that label has some value to you in terms of diagnosis and prognosis and therapy. So it's useful. That occurs in Australia. Not that common, but it certainly occurs. Next one is called chromoblastomycosis. And this is not defined by the organism, but it's defined by how the body responds and the nature of the organism as how it appears inside your body. So a lot of these fungi can do one thing in the environment, but behave and look differently when they're in your body. So with this disease, these fungi can be quite diverse, but when they're in your body, they always do a certain thing that makes them look similar. I'll explain it to you in a minute. Plus, the way in which your body responds is quite different, and you get very defined lesions that look different than any other kind of fungal disease. So it's defined by tissue form of the fungus and by the way the lesions appear on the person. Out of all of those, that's probably the worst one to get, I think. Looks the worst. Mycetoma is a different disease. It's defined by how it presents clinically. That is, the lesions look in a particular way, and it can be caused either by fungi, and we call that a eumycotic mycetoma, or it can be caused by higher order branching bacteria like Actinomyces and Nocardia. These are long branching gram-positive rod bacteria. They're almost fungal-like, and we call this actinomycotic mycetoma. Of the two, if you have a choice of having this horrible disease caused by a fungus or caused by bacteria, which one do you want? Always bacteria. They're easier to treat. You don't want it caused by fungi. Then the last one is everything that doesn't fit in the first 3. We just call it pheohyphomycosis, and pheo means brown. It means fungi with brown hyphae causing a mycotic disease that's subcutaneous. And really it just means you're seeing brown hyphal elements deep in the tissue, and how the person and the tissue responds is not like this and not like this, therefore it's its own name. That's all it means. So the first one to think about in more detail is sporotrichosis. The fungus is Sporothrix schenkii. Interesting fungus because it's dimorphic. So it exists as a mould at room temperature in the environment. It grows as a yeast in your body or in culture at 37. So it's thermally dimorphic. So if we go back to the very beginning, it's really in there but because of a number of reasons, it drops out of there down to here for most people's thinking. And it'll become clearer in the next hour why it's not up there. See, there's a whole bunch of them up here that cause a particular disease. And Sporophyx schenkii doesn't cause those diseases, therefore, even though it's dimorphic, it fits better down there in the way your map puts the fungi. But it is dimorphic. It has worldwide distribution, so it can be found anywhere. And you find it in the soil, find it in plant debris and decaying vegetation. Almost always, it's linked to some kind of occupational exposure. So you see it commonly in gardeners. What kind of gardening do you do where you often get an injury that involves penetration of your skin? What kind of plants do you have that have sharp bits on them? Roses, often called rose gardener's finger, because you get it on the fingers. You jab your finger, it gets quite deep, goes below the skin, puts in some spores, and they grow. So in developing countries, you often see more severe disease, say, on the lower limbs, but in developed countries, you see it more on the hands and maybe the wrists from gardening. What you see initially is a nodule. So a nodule means it's a growth below the skin, but initially it's not pussy. There's no opening, it's just a nodule, a lumpy bit that's a bit sort of like a little wart almost. After a while, when you leave them, maybe a month or so, they start to break down and produce pus, and they ulcerate. And then they drain fluid. Because the fungi inside the lesion move down the lymph drainage channels, you get satellite lesions. So you might have one there, and then one there, and then one somewhere else, and one somewhere else. And if you leave them long enough, they'll move up the lymph drainage channels to cause more disease. This is an Australian case, and this is someone who's been in their gardening, kneeling down in their mulch and getting it on their, what's it, on their shin, isn't it? This is after therapy, this is before therapy. So you see, starts off there, another lesion there, another lesion there. That's pretty nasty for a fungal disease. And of course, once it's open and weeping, there's always risk there of secondary infection with bacteria, Staph aureus, for example. So even though these things are often thought of as being exotic and tropical, Australia, it's not as though you're not going to see it. There's a classic case on a finger. That's the nodule before it suppurates, so it's still quite not weeping yet. Wouldn't be that sore, but wouldn't be very nice. If you saw that in your finger, you wouldn't be very happy about it, would you? This is again another case, I think, from the Northern Territory. See there, starting off 1, 2, 3, 4, 5, 6, another one there, another one there, another one further up there. So you do see these things in Australia. Don't think these things are always going to be bizarre and unusual. And if you leave them long enough, they'll break open and scab up. Ouch. This is tended to almost get dry. These lesions are not typical for sporotrichosis because they're too dry and they're too much growth heading outwards. So one of the issues with these fungi is so much depends on the person's immune response. And the worse your immune response is, the worse the lesions get. And this is probably someone with a very mild immune response, and therefore rather than being horrible lesions that break open, they become more chronic. If you left that, this will get bigger and bigger and bigger. So what about diagnosis? So again, always try to make sure you think about these things from your perspective from the laboratory. If you take a biopsy or a scraping of the lesion and look for fungal elements, it's very non-rewarding. So there's not many yeast cells, and what you're meant to see is what's called an asteroid body, which is small yeast cells surrounded by eosinophilic material in the tissue when you do a stain. if you can't see many yeast cells, because remember it's a yeast in the body, even though it's a mould in the environment, if you have horrible lesions and you can't see many yeast cells, what does that tell you about the disease? It's more about you and not about the fungus. It's about your immune response. These things just get in there and won't go away, but don't do much. It's not as though this bug's in there growing really actively, secreting enzymes and toxins and making you sick. If that was Staph aureus, it'd be in there having a go. You'd be sick because it'd be doing stuff. This just sits in there, it doesn't do much at all. The whole disease is about your immune response, not dealing with it. You can't remove them, so you end up with this foreign body reaction that sort of becomes chronic. Now, if you do culture, think about this. In the body, it's a yeast. So when you culture it from the body, you've got two choices. You can either culture it as a yeast or culture it as a mould. It works out that you get better growth and faster growth if you culture the material onto plates at room temperature and make it grow as a mould, not as a yeast. If you culture 37 and aim to grow the bug as a yeast, it's slower and less sensitive. But you would do both. You culture this at 37 on enriched media to grow yeasts, and at 25 or 20 degrees on SABS type media to try and grow it as a mould. Once you grow them, and we'll have this from the prac, I've got a few of these cultures, the bug is Dermatiaceus, but it starts off being white, and as it gets older, it goes more grey and is a bit boggy sort of material, a bit like when you see with the Zygomycetes. It's not lovely and fluffy and dry, it's a bit wet. When you grow them, most of the hyphae is still hyaline, and you have two types of conidia. Some of the conidia are born on the hyphae directly, and they're Dermatiaceous, and some of the conidia are born on small conidiophores, and they're colourless and hyaline. It's got quite interesting microscopy. You'll see some spores being brownish, some spores being colourless. Once you grow the mould, you do your identification based on morphology. Because morphology is so difficult, and it's always a bit, it's a bit vague sometimes. You think you know what you're looking at, but you don't always know. It helps to convert this from a mould to a yeast in vitro to confirm what you've got is Sporoscoptic Schenkii, because it's dimorphic. So you can take the mould on your plate, there it is, fairy mould, put that on its enriched media at 37 and turn that into a yeast. It's called an in vitro conversion. So this is a histo biopsy showing you quite a nasty disease and severe lesion. Excuse me. Watch this breaking again. On there, I can see it's a PAS stain, one budding yeast, one yeast over there, possibly one there, not convinced of that, but that one there is for sure. So it's not as though you've got lots of organism all over the place. Later on, I think next week, I'll show you infection with some of the yeasts in people's body. I've got a picture of someone's spleen where 90% of the mass of the spleen is yeast. So this would be, what, 1% of the mass of this lesion would be yeast. So it's not what you call, very aggressive in its growth. And there's a fungus. So towards the middle is older colony, towards the outside is younger colony. It's darker as it gets older. This is stained, so you really can't see the colour so much as you'd like to be able to see them, but these are the conidiophores, so they taper towards the outside. On the end of the conidiophore, it's a swollen tip. So if these spores fell off. Oh, there you go there, look, swollen tip. And you get what's called a rosette, or a little flower, of these conidia at the end. So they're oval-shaped conidia, and these are hyaline. Plus, it makes some directly on the hyphae, and these tend to be dematiaceous. Similar shape, but dematiaceous. It's got quite nice microscopy. Hopefully in the practice it'll look like that. Can't guarantee it though. And then you can convert that from the mould to a yeast, and there's the budding yeast cells that you see from conversion. If you look now at chromoblastomycosis, this is worse. And what you're seeing now is this disease is defined by not so much the organism, but the way in which the organism appears in the tissue and how the lesion appears. So it can be any of the fungi that are dematiaceous. It tends to be slow grower ones. Now we've seen Cladosporium in our pracs from our food and other stuff. Some of these are fast growers, and they're kind of a dark grey greenish colour. The ones we're talking about are the really, really black ones that grow really, really slowly. So Cladosporium, Fonseca, Phylophora in particular, are all similar. After about a month, you've got a 5 cent piece size colony. They're very slow. Very fine velvety, not furry, very fine velvety colonies, slow growers. And what you see in the tissue is these fungi are not dimorphic. They only grow as moulds. But in the tissue, in infection, they don't form hyphae. They form this weird thing called a sclerotic body. Sclerotic body. And it's kind of like, I call, a pseudo yeast. You cannot make those things in vitro, but in your body, the way your immune response hits this fungus, it stops growing like a mould and grows as this funny, multicellular, round, yeasty type thing. They don't bud to grow, but they start dividing internally, and they can divide in more than one direction. So we call that multiplane septation. And is there a picture of one? Oh, should be somewhere. Oh, I'll find it in a minute. There is one there, a few slides away. They're kind of like brown, copperish, like a penny sort of shape. They're round with little septatia that goes in more than one direction. So it's similar in the way this occurs as to sporotrichosis. It involves injury, implantation of the fungal elements into your tissue. But then what happens is, because the bug is so slow growing, you make a different kind of immune response and different kinds of lesion than you do with sporotrichosis. These bugs are different, and the way you respond is different. And you end up with lesions that grow outwards. So the swelling and the lesion starts off growing out from your skin. They're growing outwards. And your body's response is to make the skin covering of those lesions become hyperkeratotic, so it's like really, really thick, dry skin. And you have hyperplasia, so it's like a tumour that's going externally, and the tumour is hard. And often think about a cauliflower flowerette. Imagine one of those things made of skin stuck on you somewhere. That's what you see. From injury to the full-blown disease might be 5 or 10 years. You'll see something maybe up to 12 months, but you see the full deal after a long time. So you only see full-blown disease in a developing country where health access is not so good. Hardly ever see it in children. Could be 2 reasons. They're too young to have had the time for the bug to develop and the lesions to develop. But it may also be an immune response thing, because this is all about the immune response. The bugs aren't doing much other than just being there and being annoying. I think of these things as being like a splinter that's made of fungus that's growing. It's really about what your body tries to do to remove the splinter. The bugs aren't growing much. When you come to treat these things, it's complicated because any bug that's slow growing is hard to kill because all antibiotics, whether they be antifungal or antibacterial, they work on a growing cell because the cell's got to metabolize to suck the drug in and then the drug kill it. If the bugs aren't metabolizing very quickly, they die slowly. So TB, slow grower, dies slowly, long-term therapy. And these things are the same. You can take antifungal drugs, but because they grow so slowly, it's pretty poor. What else do you think might be a problem with the drug therapy? Think about the lesions when we see them in a minute. Because they're not very vascular, drug access, take the drug in your blood, doesn't get down to there where it's needed. So you get low levels of drug at the site of infection. Often means surgery because even if you kill the bug, you can't undo the big growths on your skin. You've got to cut them off. And you can use heat therapy. All these things grow better and really only grow well at room temperature. That's why I see them on your extremities. And if they're in lesions that are external to your true core part of your body, they'll be cool. So you warm them up, use heat therapy. That's a really advanced case. So that's not what you wouldn't get that in 24 hours or even a couple of weeks. That would be years and years and years. And even if you went like this now and said all fungi be gone and be dead, this stuff stays there. So you still need surgery afterwards to get rid of all the tissue. And of course in those countries surgery wouldn't be an option because it would be too expensive. If they break down, you can imagine that's bleeding. So the trauma there will be open wound, Staph aureus, sepsis. They're pretty horrible, aren't they? So all diseases, fungal things are the worst, I reckon. So for diagnosis, you take a biopsy and you look in the biopsy. What's different now is compared to sporotrichosis, you do see lots of these sclerotic bodies, so it's quite easy to diagnose on microscopy. Hyphae is uncommon because what happens is your immune response makes the fungus grow differently like this yeast. We have this obsession with media being full of cyclohexamide because it kills things that are saprophytic and lets us grow dermatophytes. But a lot of these fungi are saprophytic, so you can't just culture always on mycobiotic agar because you're going to get growth of other things. So you'll stop some of the bugs growing. Some of these things can resist cyclohexamide, but most of them can't. So you must use media that doesn't contain cyclohexamide. Have a think about what you saw in the prac on some of the plates that didn't contain cyclohexamide. What you had was overgrowth of penicillium, aspergillus, every other bit of crap in the air gets on your plate and grows. Imagine having this horrible lesion on someone's foot and you're culturing for a fungus with media that's not selective, and your target fungus grows as big as a 5 cent piece in 6 weeks or 4 weeks. The chance of getting that culture to go to completion without being overgrown by aspergillus or penicillium or a zygomycete is pretty minimal. So there's a problem here with contamination because these things are slow and contaminants are very, very fast to grow. So you've got to be really, really careful. It's okay if there's contamination coming from the bit of skin, but make sure your plates don't get lab-based contamination. How much of the contamination in your food, on your plates, or the ones for growth rates were caused by lab contamination, and how much by other contamination? It was all lab contamination. Every time you open up a little bag of your bit of cheese or your bit of eggplant, I love that in a minute, up they go, spores everywhere. So you just got to stay careful. In the prac that we do in a couple of weeks' time, what I do, just to show you how bad this is I put plain agar plates, lids off, on all the benches and leave them there for the whole prac. Don't touch them, and then next week, after having a week to growing, I'll show you what's on the plate. And the amount of stuff that comes off those plates when you're doing your tape preps is stacks of it. So mostly you should be doing all your microscopy in a safety cabinet. Now it's fine with things that are not inherently nasty, but there are some nasty fungi out there that can cause disease in healthy people that you've got to be aware of. Now in the practice it's controlled, so I know what we're playing with, and when there's any risk I'll put you in a safety cabinet, but other times we're okay. But I mean, in a real laboratory, you do all the mycology in a safety cabinet, because there's a couple of fungi that you can come across without knowing about them that cause disease in laboratory workers and can be really nasty. Ah, there you go. There's the sclerotic body. So this is some tissue and done digestion. This is unstained. The brownness there is the brown from the organism. Remember, they're dematiaceous, and even though they can't make those things in vitro on your plates, this is a combination of fungal growth meeting immune response and changing in response to the immune response. And there's one inside histoprep. So this stain is good for the histo stuff. This colour there is natural colour of the organism. It's a sclerotic body. Stacks more there. Now here's the problem. Sometimes I really hate mycology because it's too difficult. All these fungi, Cladosporium, Fonseca and Phyllophora, when they are doing the right thing, have particular microscopy that fits the organism. So there's a kind of spore that you see that's typical for Cladosporium, and spores you see that are typical for Phyllophora. Sometimes a Phyllophora can, just for a small amount of time, have conidia that are more typical of Cladosporium and vice versa. It means that when you do microscopy, you're never quite sure what you're dealing with. So I think the sooner we move to molecular-based tests for these, the better. But all I can try and do in the practice is show you what's typical and leave it at that. But it's not always that straightforward in a real laboratory. You need to have some sort of backup plan besides just microscopy. So that would be a 4 to 6 week size growth on plain Sabs agar. So they're very, very small, very fine, velvety sort of colony. So you would have seen in our pracs we have some Cladosporium, and Cladosporium, not sure you can see the branching there very clearly or not, probably not actually. So Penicillium, the conidia are round, have the same kind of head, but they're round and they form longer chains. These chains are shorter, and these chains definitely branch. Not sure you can see one that's branching necessarily there. Maybe up there, there's a branching one. Branching chains don't occur in Penicillium, but with Cladosporium, they branch. Look, I think the chance you should mistake Penicillium for Cladosporium and vice versa is negligible, because Penicillium is much rounder. The colonies are more green, they're faster growers. These are much slower growing. And these conidia are really clearly dematiaceous, and you wouldn't see that with Penicillium. That's a better example of Cladosporium. It's unstained, and this is a faster grower one, but has better microscopy. And there the chains, you probably, oh there you go, there's a branching chain. So one phyllide, but 2 chains of conidia. If that was Penicillium, it'd be 1 phyllide and 1 chain that would be round, not, these are like a shield shape. Ooh. Sometimes they're browner, a bit faster growing, but in the end, the cloning morphology is not helpful other than to say it's a slow growing fungus that's dematiaceous. This is Phyllophora, and these are beautiful because they form really nice phyllides. So there's the conidia, the hyphae rather. This is a phyllide, a specialised kind of conidiophore. And you'll see at the very end there, like a little collar. This in fact is a tube, and these spores don't grow on the outside. They get shot out there. They grow in here, and they sort of spurt them out. And they form these big clusters together. It's almost as though they're glued together by something to stay together. So they're oval shaped, and these are really quite distinct. So for your diagnosis, seeing sclerotic cells is mandatory. You've got to see those. Even though it's got this pseudo yeast form in the body, you can't do conversion in vitro. It only ever grows as a mould in the laboratory. In the end, though, you'll see really variable formation of conidia. Can be quite complicated. So you need to have really good preps and someone who's an expert, which is not me. Then we have mycetoma. Again, this is now a different kind of a disease than chromoblastomycosis. Eumycetoma means they're eukaryotes, they're fungal. Actinomycetoma if the bugs are actinomycetes. Remember, actinomycetes with a T are aerobic, gram-positive branching bacilli that are found in the soil. Actinomycetes, when you grow them, they're slow growing, and the colonies are almost getting to being fungal. They're hard, adherent colonies, and they smell like soil when you smell them. With this disease, the swelling occurs inside the tissue, not outside. So the outside surface is still pretty normal. It's all happening inside the tissue, subcutaneously. And you have this big swelling that's pus producing. In the end, if you've got some big swelling area inside your body, often on the feet, maybe on the hands, when it swells, it's full of pus. At some point, the pus wants to come out, and it forms a sinus. So a sinus is basically a tube that drains the pus from an internal lesion to the outside. Because the fungi grow in this broth of blood and pus, with bacteria, I mean normal bacteria that are single-celled, they just grow everywhere, they're diffuse, but these fungi grow in little focal lesions, like a little granule. So you get a granule that's just all colony, all organism. And if you take the pus and you can wash the pus with some saline, wash it all away, what's left behind is a granule. If you squash the granule, it's all organism. So the granules can be quite good to recover. Again, it's all about implantation and trauma, and they're non-contagious. These are all the same in terms of their epidemiology. Not contagious, because you've got to have not just the bug, you have the bug plus the trauma. I suppose the only way it can be contagious is if someone had this disease and they kicked you, and when they kicked you, their leg broke and their bone went into your bone, then maybe. It's pretty unlikely. It will spread in the person, so it will spread and go from one primary lesion, spread internally, can go and form disease in the bone. Once it's in the bone, it's all over, because bone disease is really, really, really hard to treat. Of the two, this is better. We've got better drugs for bacteria and not as good for fungi. That's the bottom line really with therapy. Just harder to treat. With eumycetoma, it can be any kind of fungus you like. Sometimes they're dematiaceous, other times they're hyaline. The hallmark of the disease is the way the lesion is. This swollen sinus thing, internal swelling. We tend to see it most commonly, in Australia at least, caused by Pseudo-Alascheria boydii. I should change the name. This is a fungus that has two different names. One name is a sexual name and one is the asexual name. And I just find this whole sexual thing, asexual thing, really, really irritating. I don't really, to be honest, completely believe it and understand it, but it's the way that it is. I don't like it either. So most often when we grow this organism, what we see is the asexual form. So strictly speaking, we should refer to that bug not as Pseudo-Alascheria boydii, but Ascetosporium apiospermum. Fusarium, this fungus here I've never ever seen before in my life, so I can't even tell you what that's like, but these are much more common. Exophiala genselmii, black fungus. So this can also cause chromoblastomycosis. So whether this bug is causing this disease or the other disease is not defined by the organism, but defined by how it presents in the person. Of the ones that are actinomycotic, they're nocardia, streptomyces. These are all just gram-positive branching aerobic rods. To make them slightly more complicated, as well as the actinomycetes with a T, which are aerobic gram-positive rods that live in the soil, we also have a bug called actinomyces without a T. Actinomycetes with a T is a generic term that means all the bugs are aerobic gram-positive branching rods. Actinomyces with no T is a genus name for gram-positive anaerobic branching rods that live on mucous membranes. It's possible sometimes to get a kind of mycetoma-like disease that occurs in parts of your body where there's mucous membranes and some trauma. And the most common would be a facial injury that involves bone breaking inside your jaw and implantation of endogenous actinomyces anaerobes in your mouth to form kind of a lumpy thing on your jaw. So this is kind of a sketch. Foot on the outside is kind of normal. All these things here is growth of fungi, and all these tubes are drained to the outside. They all communicate and they drain outside here, the pus comes outwards. It can be more than one sinus, it can be all over your foot. They're really horrible. There you go, horrible. Now that would be a 10-year disease process, wouldn't be like 6 months. This is a lot less nasty, but you see there it's weeping, and that fluid coming out of here will contain fungal elements. Weeping over here. This is a biopsy, and this is the outside of the foot, and that's showing you the drainage channel from the inside. And all that stuff there is pus. All these black dots there are granules that contain fungal elements. So if you've got that pus there and washed that, you can leave those behind like little rocks, and you squash them, and they're fungal. This is somebody's jaw, and that would be one of the ones caused by actinomyces, the ones that are anaerobic. Being punched in the face. And look at his lips. If you saw that, you'd want to punch him, wouldn't you? Look at this horrible, miserable face. And that's one that's burst. What's that? Don't like it? I once had a student, seriously, this is the truth. I had a student here, it's been, how many years ago? Maybe 10, more, perhaps. And came to me in microwave. She knew I had this love of showing gory pictures. And she was really quite strict about certain things. And she said to me at the start of the unit, she said to me, Stephen, if you ever show pictures of penises in the lecture, I want you to let me know in advance because I'm leaving the room. She did. When it came to STI lecture, I had to say to her, today we're going to show a few dick pics, and she left before I came on. It was really quite, for me it was quite confronting. I thought, well, in the end, it's your job. I mean, you still got to see them and sort of get an idea what it's like. She's not interested. So for diagnosis, what you want to get is to recover the granules. So the pus comes out, so you would collect the pus with a syringe or maybe a swab, but a syringe is always better. Wash them, look for the granules. In general, if the granules are white, it's most likely bacterial, actinomycetes. If they're coloured, particularly if they're black, probably going to be fungal. It's not that useful really in the end. You aren't going to go, oh, it's this colour, therefore it's this. Here it is on my microscopy, have a look. Squash the granules, broad hyphae, so if it's fungal, they're going to be quite thick filaments. If they're bacterial, much, much thinner, because fungi are thicker than bacteria. When you culture for everything. You won't know whether yours is going to be fungal or it's going to be bacterial. Cover everything. When we're culturing for fungi from sites that are external, the preferred media is Sabs agar. When you culture from things that are internal, whether it be blood or bone marrow or a lesion aspirate or even a piece of tissue, we tend to prefer to use a thing called brain heart infusion agar. I'm not really sure why it is, because most of these fungi grow well on Sabs anyway, but almost always in methods you see brain heart infusion agar, it's more enriched. It's less selective in that it grows bacteria as well as fungi, but it is the preferred medium. If you've got bacteria, now this slide probably is redundant now. Historically, when you grew these bacteria, they were slow growing, really weird. You do Ziehl-Neelsen stains and all these funny stains on them. What would you do now if you grew the bacteria? You go Multitoph and get the answer. It'd be really, really easy. So, look, if you haven't got a Multitoph, then working out what these bugs are, whether it be Nocardia or Streptomyces, is a bit tricky. It involves doing lots of different stains. And because they grow so slowly and are not fermentative, you can't use API strips and things like that. It's back to good old basics. Get the book out, do a whole lot of weird tests, or ring up the Multitoph people and put it in their machine and get the answer. Your choice. This is an example of a histo slide. This is all body reaction. This is all fungus. This is all organism. So the granules you form, they grow like a granule. That's what you see. This is a silver stain, all fungal hyphae. I don't know what that is. There aren't many fungi that, this doesn't scare me, I guess, because it's not going to hurt you unless you're sick. But if you ever get sick and someone grows a fungus from you and says, by the way, Steve, you've got Scedosporium, these fungi are the hardest to treat of everything. So this is Scedosporium apiospermum. So you have long ctenophores and normally only a couple, either terminal oval ctidia or sometimes lateral from the side of the ctenophore. Now, because Scedosporium apiospermum is a fungus that we know has got a sexual state, sometimes the bug will reproduce sexually on your plate, because some fungi can be sexual, and we call those heterophilic. It needs two colonies of different mating types to mate. Sometimes they're homophilic and can become sexual with themselves. And this is a sexual spore of what was before Scedosporium, but now sexual, it would be now called Aliceria boydii. It's called a Cleistophecium. And you can read books, there's all these special tricks you can try and do to make your Scedosporium have sex with itself on the plate. And I have tried and tried and tried, won't do it for me. So I've tried, because I'd love to see one of these in the prac, but I can't get it to work. But these can occur just randomly on a culture plate. But most often it'd be like that in its normal asexual stage, the Scedosporium. For the last 15 years, there's been quite an advance in different kinds of azole drugs, and this is just showing you that Scedosporium apiospermum and the other relative Scedosporium prolificans are relatively sensitive to voriconazole. This was, at the time this slide was made, quite a new drug, but even now, most strains of Scedosporium are totally resistant to all the azole drugs. They seem to mutate pretty quickly. I would think about these bugs as being the Pseudomonases of the mycology world. They mutate quickly and resist lots of drugs. This was topical once when I first wrote this slide, and we had lots of students then from Thailand. This was a pop star in Thailand who crashed his car. Now, Scedosporium often lives in stagnant water. And this bloke, this pop star, crashed his motorbike or his car into a ditch on the side of the road and aspirated Scedosporium spores. And he was okay after the accident, had surgery, got okay, and then a few months after the surgery started being ill and went into a coma, and they found Scedosporium through his body in his brain. And he was in a coma for months and months and months. Came out of the coma. He died, I think, a number of years afterwards from Scedosporium. And I remember being at a talk a number of years ago with a mycologist who was giving a case series presentation about car accidents in America, in Boston. And they have lots of these ditches on the side of the road. And he would have had 20 cases of car crashes where the person goes into the water, aspirates some of the water, Scedosporium invades, goes systemic, horrible organism. You may remember this. I'm trying to think. It's now 2018, 97, that's 21 years ago. Were you alive then, most of you? You weren't born yet. You were born 97. This is what scares me the most about how old I'm getting. Because this to me is still so clear in my mind. It was big on the news at the time. So the Maccabi Games, as I recall how it works, is it's like a mini Olympic Games for Jewish people. And you go to these games and all the athletes were crossing across this bridge, and the bridge collapsed when they were on the bridge. And there's a picture of the people in the water. I think one person died from injury from the crash, and 3 people afterwards got infection from this water with Scedosporium. And a number of them died from Scedosporium infection, got from the water. So one young girl, I think she was 18 at the time, brain abscesses, horrible, horrible thing. A couple of years ago I had a student do a case study presentation on this same organism, and what she had was awesome. There was a bloke on a farm, and he was using pig manure in a vat to make methane to drive his own power plant on his farm, to run his farm. And one day he was up on the top of his vat loading in some more pig manure, and he fell in. And he almost drowned. So he got saved from being drowned in the pig manure, got pneumonia, got cured from that, and then 6 months after that got Scedosporium growing in his brain, died from that. So Scedosporium, not nice. So, quick summary. Of all these things that are subcutaneous, they all have one thing in common. It all involves traumatic implantation of the fungal elements from the environment. These fungi are environmental. What disease you get depends on a couple of things. How you're exposed, what your immune response is like, what the organism is, and how you and the bug interact. If your infection is caused by Sporothrix schenkii, it's sporotrichosis. If it's caused by any of the dematiaceous fungi and forms a sclerotic body inside the tissue, and you end up with wart-like growth, we call that chondroblastomycosis. If your lesions are internal and they're swelling with sinus formation, that becomes mycetoma. Anything that's not in that group, we just refer to them by the terms pheohyphomycosis, means brown hyphal elements in the tissue, or halohyphomycosis means the fungal in the tissue is hyaline, not brown. That is an infection caused by a brown fungus. This one's called, by a fungus called Weinerella. And this person's got leukemia, and these lesions here are occurring because the fungus has got into her body and it's coming to the skin from the inside out. Bloodborne first, onto the skin. I mean, for this person now, having leukemia and being neutropenic, you either fix the neutropenia or it's going to die. You can't treat this. This is just systemic. That one's nice. There's a picture on someone's, lesion on someone's thumb. Obviously been gardening and something's put the brown fungus in there, and this brown coloration there is the brown hyphae in the tissue. It's exophiala. So there's the lovely firelight and these clusters of ovoid conidia. Right, let's have a breather. It was a big session, wasn't it? Sorry about that. So it's 10:15 by that clock. It's right now. Now we'll restart again at 25 past 20 past. Your call. 25 or 20? 25, says Gabriel. Okay, 25 past. Okay, I'll make this kind of simple. With this whole section, treat this as being one kind of infection and one organism. Because lots of things here are very common to the whole group. There'll be a couple of occasions, give me the feedback now, I hate this. A little bit lower. There'll be a few occasions when I'll say to you, for this particular example, this is really important. And then remember the name and the thing that's specific, otherwise treat these all as one big group. So these dimorphic fungi all cause disease that's systemic. In other words, you breathe them in, they usually cause either a mild disease or they're subclinical, or you're colonised, you form an immune response, you're antibody positive, you're never sick, they go away. Sometimes they cause disease. Most often it's pulmonary disease, but it can spread from the lung to go somewhere else systemically, can go to your brain, can go to other lesions, can come out your skin. They're very diverse, depends so much on your immune status. They're much worse if you're immunocompromised. So there used to be 4 of these, there's now 5 of them. Histoplasma capsulatum coccidioides immitis, Blastomyces dermatitidis and Paracoccidioides brasiliensis were the 4 initial ones. These are all dimorphic. They grow as moulds at room temperature in the environment. They grow as yeasts at 37 or in your body. This one's got a question mark because even though it's a yeast-like form in your body, you can't make this become a yeast in the laboratory. But it's in this group because it's got so many things about this that are the same. And the new one used to be called Penicillium monefii. It's a plain old boring penicillium. The colony is quite different though, but it's also able to be dimorphic and can cause disease and is really important in Southeast Asia. Vietnam, Cambodia, Laos, those kinds of areas become quite important. Because people think penicillium boring is batshit, doesn't cause disease, they've renamed it now Talaromyces. And just thinking that when I said boring is batshit, there's a connection there because some of these bugs live in bat droppings. Didn't realise it, so I said it, just came out. So Penicillium monefii, now called Talaromyces. So here's the common features. They're all thermally dimorphic. Moulds at room temperature, yeast at 37 or in your body. They all cause infection by getting into you via inhalation of the spores. In the environment, they grow as moulds, make lots of spores that are dispersed in the dust, and you breathe them in. There are definitely, for some of these fungi, a particular niche that's very, very common. So some grow in dry soils, some are more common in caves around bat droppings. So each bug's got its own niche that's peculiar to that particular organism. And most commonly, they're asymptomatic. And we know that because if you do surveys in areas where the bugs are endemic, take blood from volunteers and look for antibody, a large proportion of the population are antibody positive, which means they were infected, but they were never sick. That's most common, or that's most common. You only get disease if you're unlucky, and it might be something to do with your immune response, might be the amount you're exposed to, could be a whole lot of different factors. In the same way that things like Neisseria mentitidis, some of us are colonised in the throat with no disease, others get meningitis and die. That's not about the bug, it's about you. Same with this, it's more about you than it is about the organism. Here's the four, and showing you on the left in each example is the mould form, on the right the yeast form. So Blastomyces, not particularly exciting. Now all of these fungi, apart from Tallaromyces monifii, all these fungi have one thing in common with their culture: they're white fluffy moulds. Beware the white fluffy mould, because if these things cause disease by inhalation and you're in the laboratory as a white fluffy mould and you're making spore preps, what's going to happen? You breathe them in. That's why we never do microscopy on white fluffy moulds without doing it in a safety cabinet. Unless you're in there in my lab where I know what the bugs are before you even start playing with them. So Blastomyces is not particularly interesting. It forms yeast forms. Histoplasma has really awesome conidia. Never seen one because they're so dangerous, but the yeast are nondescript. Paracoccidioides as a mould, not very interesting, but has great big ship's wheel yeasts in the body. And of all of these three, the one to be particularly aware of, and remember this name, is Coccidioides immitis. The reason being, it's of those four the most aggressive, and it's also the one that forms the most conidia that are easily airborne. So it forms hyphae that break off to form arthroconidia. It makes lots of them. They're breathed in very easily. There are countless numbers of cases where this has caused disease in laboratory staff who got a white fluffy mould on the bench, played around with it, breathed them in and got sick. In the body, it doesn't form a yeast, but forms a tissue form called a spheruole. It's a large enclosed body with a number of spore-type yeast things inside it. You can't make this happen though in vitro, it's only in vivo. So there's a quick summary of the kind of disease you can get. Remembering that from there above, this bit here is what's most likely. But then it can be either an acute disease where you're exposed and you get pneumonia and you're sick quickly. It can be a chronic disease where you get sick very slowly. It could be 6 to 12 months. It might just be purely pulmonary. It might disseminate. And this means it goes to your spleen, to your bone marrow, to your brain, wherever it wants to go basically. Sometimes what's even more disturbing is you may be subclinical in the pulmonary primary disease, no disease at all, and the first time you know what's going on is when you present with primary lesions on the skin and they do a biopsy and they tell you you've got disseminated disease caused by a dimorphic mould. It'll be through your body, it's got to be everywhere else before it goes to your skin, but the first time you see it is on your skin. For diagnosis, we can do skin tests by putting antigen a bit like a BCG and look for a skin reaction, and you can do tests look for antibodies. So if you want to screen to look at exposure, those tests are useful. But those tests aren't useful to diagnose individual diseases. It's more about looking at the epidemiology and the rate of exposure in a particular environment. To diagnose, it means culture. Got to do culture or microscopy from any kind of body fluid where you think it might be rewarding. It might be bone marrow, it might be blood. It just depends on where the person's got the disease. And these things are all inhibited by cyclohexamides, so you must use plates that are non-selective. And then you have just growth of a white fluffy mould. You then do conversion. So once you've done the microscopy, taking all the precautions that you've got to take, to prove beyond doubt that what you have is what you think you have, you've got to convert that from the mould to the yeast in vitro. You can't do that with coccidioides though. And on top of that, there are now good molecular PCR tests that will prove what you have is what you think you have. So really, I think these things are probably going to become less and less important over time because molecular tests are getting so good. I can't stress this enough about the risk of laboratory-acquired infection. You have to make sure that you handle white fluffy moulds in a safety cabinet, especially if you're culturing from any sterile site. I mean, it's one thing, if you just got a skin lesion, it's pretty fair game, it's going to be pretty safe. But if you're culturing sputum or bone marrow or anything else and you grow some mould, be really careful. The most common thing that we grow in Australia from, as a mould from sterile sites is Scedosporium, and that appears as a white fluffy mould anyway. But you won't know until you do your prep, and by then you've been exposed, so do it in the safety cabinet. I can remember hearing this story from David Ellis, who is a good mycologist in Australia. He had a case where a poodle had got infected with coccidioides. Don't know how it got coccidioides. And the vet grew this fungus from this poodle's sputum. How does a dog buck sputum? I don't understand how to do that. But a vet grew this fungus from this poodle. And see, if we send specimens from human pathology through the mail, there are all kinds of regulations. It's really strictly controlled. If you're a vet from an animal, you do what you like. So David Ellis received a parcel from Australian Post, a simple agar plate, no tape, in a padded bag, and when he got it and opened it, it was coccidioides. I mean, the risks from that are horrendous. So these days it's strictly controlled if it's human, but not so much for animals, I don't think. I can remember, this is true, when I lived in Darwin, I went there for a holiday and I wanted to bring some cholera back to use for culturing for pracs. And this was before it got really strict. I can remember coming back on a plane from Darwin to here with a culture of cholera in my top pocket. At the time, to me, it seemed perfectly reasonable because I thought, well, it's in a tube, it's safe, what's going to happen? I couldn't do it now, you'd get shot, you get caught doing it now. This was a long time ago. So, histoplasmosis, worldwide distribution, so it has no particular niche. Definitely more common in areas where there's bird droppings. Now, whether the birds are some kind of reservoir or whether the fungus just likes the environment around bird droppings, maybe the soil is more rich, I don't know. But you do see cases in Australia, and just out of interest, in some parts of America, there are locations where these signs are put up because this soil in this area is known to be heavily colonised with the fungus, and there's warnings about don't go in there and start digging around in the soil. Because you're all so young, do you know who he is? Thank you, you do. He had that infection in 1997, I think, on his European tour at the Kensington concert, had pneumonia. And the reason I like that is blown in the wind, he got the disease by inhalation of wind-blown spores. Now, this won't be on your slides, this is new stuff, because last year on my notes I went, this is too short, add more content to this year's lecture. And this year I'm running behind time, so I shouldn't even put this in there. But just quickly, this disease is much worse if you're HIV positive. Here's a person who walked in, she was still alive and still pretty okay, losing weight, from Africa. Hemoglobin was very, very low, 73, wasn't diagnosed yet as being HIV positive, but initially on the blood film saw yeast cells in the blood, and this ended up being disseminated disease with histoplasma. And even though the positive culture was obtained, she was dead before the culture was positive. So these are chronic diseases, but if you're immunocompromised, always going to be worse. And if you've got a place where the bug is endemic, where HIV is also endemic, you've got two things that intersect which are nasty. Which other bug do you know tends to intersect so strongly with HIV? TB, yeah. TB, HIV go together, horrible. Same thing here. HIV and any of these dimorphic fungi that are going together are nasty. There you go, a what? Fluffy mould. Nothing spectacular about that. There's the microscopy, quite spectacular, so quite typical. There's the mould. So it's gone from being like that to like that just by temperature. And there's the yeast form on microscopy. A fairly old-fashioned method of diagnosing disease was called immunodiffusion. Do you do these in immunology? We used to. I think we've all moved on from when I was a student, haven't we? The good tests, though, they're quite robust tests. What you do is, in the middle is your test. You take the colony and you do an extract of the colony to get all the antigens together. And then in these wells you have antigen and antibody. And where this antibody and this antigen control meet together, it precipitates. So this is histoplasmic antigen, histoplasmic antibody. And where this culture extract meets this antibody, there's a line of precipitation, which means whatever is in there reacts with this antibody, therefore your culture was histoplasma. Given the choice of doing that or doing PCR, I'll do PCR because it's easier. Blastomycosis or blastomyces dermatitis, again, a fungus in the soil. Don't see it in Australia, but you do see it in Asia, so there's a risk we're going to see that from imported cases. And this is primary disease that would have been pulmonary to start with, coming out on the skin. This is a 20-year chronic case, but you can see how it's incredibly disfiguring. Now this obviously is someone who's got no access to healthcare, gets sick, puts up with it, but it's really horrible. And these fungi are really horrible. That's the same patient. So skin's weeping. And there's all the yeasts inside. That could be a biopsy from the skin probably. Excuse me. Coccidioides is not endemic to Australia, so you won't see this other than being imported. Now, if your disease is primarily pulmonary, sometimes the fungus grows and forms a sinus where your lung connects with the outside of your body through your skin. So it's come up, this is a lung lesion that's come out, back up through the top of his chest. Are you scared yet? Again, 20-year case. You can't undo that damage. And there's a biopsy, there's the spherules. You can't make those in vitro, but you do see them in vivo. And a simple white boring mould. See it all the time. And microscopy on the mould, there's all the arthrochinidia. So that's what's so infectious. this is great. So again, this is new content that was in there last night, just for interest. So this is a Chinese man who's unknowingly been travelling to America, but he's back in China and he's got a bit of a cough and he's feeling a bit flat. They do a sputum culture and grow nothing. Do a CT scan of his chest and go, "You got lung cancer, mate." Take a biopsy, do some cytology, negative for lung cancer. Because they're scared that he might die, they cut his lung out. And then, after they cut his lung out, they do some microscopy on the biopsy and find coccidioides. There's the spiral inside his lung. Now, the sad thing is, this was entirely treatable without having your lung taken out. And they didn't find out this till after the lung was already out. The point of this is, without suspicion, they didn't know he'd been to Arizona. In Arizona, it's endemic. In China, you never see them. And it's the same for us in Australia. If we don't have some suspicion about these things, you won't look for them. There's always a risk that you won't think about things that are exotic because you just don't see them present here at all. So in the end, his lung taken out. He survived. He was all okay, but a bit breathless after that. This is paracoccidioides. And again, look, these things are all the same, apart from a couple of unique things. And you'll see the same thing over and over again. Pulmonary disease that often manifests as a cutaneous infection. HIV positive patient, lesion on the roof of the mouth. That's paracoccidioides. And there's the ship's wheel morphology of the yeast in vivo from biopsy. This is a ripper. So this person is doing some research on paracoccidioides, and because he's mean, he's playing with guinea pigs. And he's got a suspension of the fungus in saline to squirt on the guinea pigs, and hits his thumb by mistake, and squirts all these organisms into his thumb. So remember, these things are not contagious, and the yeast form is not meant to be able to cause disease. You've got to breathe in the mould form. But if you inject the yeast form into your thumb by accident, even though he'd had some prophylactic fungal therapy, at day 7 his thumb was all swollen and tender, and they took a biopsy of his thumb and they found ship's wheel yeast in his thumb. That was his thumb being swollen. In the end, once they cut that out and gave him some therapy, it was okay, but serves him right for being mean to guinea pigs. I like guinea pigs, I have pets guinea pigs, until this was about a year and a half ago. I got home, went to go and feed them, and I thought, oh, it's bad karma, the cage is upside down, and a dog had got into my cage, and he just chewed every single one of my 10 guinea pigs, and then spat them out. It was horrible. It was horrible, horrible. I'm still scarred by it, poor little things. I felt so bad. Okay, so as it stands right now, with the dimorphic fungi, what you've got to remember is they're all the same. They mould at room temperature in the environment. You acquire them by inhalation. Disease can be variable depending on what you like. Of all those four, the one that's peculiar and special is coccidioides because it's so dangerous and aggressive and makes so many spores so quickly. Have that one in your mind as being a little bit more special. The other one that's special is Talomyces monifii, old name penicillium. There's two reasons why this to me is special. Three reasons. The first reason is because I said. The other two reasons that are more important though is it's a penicillin. And when we see penicillin on any kind of culture, our first mindset is contamination, chuck it out. And you grow penicillium specimens of species all the time from sterile sites because they're in the air on everything, and your first thought is contamination. Just remember that sometimes it might be a real pathogen. And the second thing is it's endemic to parts of Southeast Asia, and we have lots of Asian people in Australia. We go there and travel and come back, like I've just done, and we might bring the bug back with us. So we should think about this bug in our own context, because it might be more common than you might think. The good thing is that even though it's a penicillium, the colony is quite special. It's a green, good old penicillium, like they all are, but it has an orange pigment on the reverse that's diffusible. If you ever see a penicillium with a hint of orange on the reverse of the plate, start thinking about what this might be. Historically, it was linked to HIV patients. All the first cases were all in HIV positive patients, except starting in the late 2000s, the number of cases in non-HIV patients went through the roof. So what's happened to make non-HIV patients suddenly get Penicillium aeruginosa, or Talaromyces aeruginosa? And the thing that's happened is the countries where this bug is endemic are getting better and better and better at keeping sick people alive. Historically, if you're in those countries, poor healthcare, and you got leukemia, you died. And now you stay alive and you go home to your village and exposed to these bugs in the cane fields, and you breathe them and you get disease. So we're seeing now a lot of disease in non-HIV patients, but they're still immunocompromised. I mean, they're still immunodeficient, not by HIV, but by something else. I'll skip through that, it's not important. Not important. This person's got HIV, and the first presentation is lesions on the roof of their mouth. And this is microscopy from a biopsy, and there's the yeast cells, and they are yeast cells that have been formed by dimorphic conversion of penicillium mould into a yeast. And this is a blood film. In the blood film, intracellular yeasts inside some white cells. So this bug is, of all those 5, this is the one that I think that you people here might be exposed to in your working lifetime. There you go. On the colony, not hard to recognise that. Even though it's a lovely green mould, the pigment is quite distinctive. You couldn't miss that, could you? If you had any sort of, if your mind was even half switched on, you wouldn't miss that. Just don't throw away penicilliums willy-nilly if the specimen is a sterile site, because it might be important. On microscopy, simple, normal, old penicillium. It's now called Talaromyces. Right, the quiz will start at 11ish. It's not that hard, don't agonise about it, just relax and be confident in what you're saying. Don't write too much, just write good things. And what I'm about to say now, I'm going to regret.